Many times, as medical professionals, a person with an intestinal stoma comes to our consultation, and it's necessary for the primary care physician to know what it's about, in addition to identifying the most frequent complications and being able to refer them promptly to a general surgeon or colorectal surgeon. Hello, I'm Dr. Jesus Macias, and in this video, I'm going to talk about intestinal stomas. Intestinal stomas are used as temporary or permanent means of fecal diversion in the management of various gastrointestinal, neurological, and genitourinary conditions. It is estimated that 120,000 stomas are created annually in North America, with an estimated prevalence of ostomized patients ranging from 450 to 800,000. They are named according to three characteristics: the location of the intestine, type of configuration, and temporality. According to the location of the exteriorized intestine, they are called colostomy, ileostomy, and jejunostomy. They can be configured in two ways, terminal or loop, depending on the surgical strategy and perioperative conditions. I want to clarify that the term terminal refers to the configuration of the stoma, not its temporality. That is, terminal doesn't mean the patient will have it for the rest of their life. This leads us to the last part of stoma classification, permanent or temporary. So far, we can define the most common configurations, which are terminal or loop ileostomy and terminal or loop colostomy, generally sigmoid. If we observe a patient with a stoma, we can identify the type of stoma it is. Generally, stomas located in the left hemiabdomen are from the colon, mainly sigmoid, although they can also be from the transverse or descending colon. In the right hemiabdomen, small intestine stomas are generally located. Ileum, it's called ileostomy. This is the most common scenario, but it's not a rule, as a colon stoma can be on the right side and an ileum stoma on the left side, depending on surgical findings, technique, and surgeon's choice. Now, to define if a stoma is terminal or loop, we just need to observe the number of lumens it has. If only one lumen or light is observed, it's terminal. If two lumens are observed, it's called loop. Now that we know what an intestinal stoma consists of, I'll talk about the indications for performing a stoma. Indications. Colostomy. The creation of a terminal colostomy may be indicated in various benign and malignant diseases for permanent or temporary enteral drainage. In the following table, I summarize the main indications: lower rectal cancer, recurrent anal cancer, severe anorectal Crohn's disease, or severe radiation proctitis may require a permanent terminal colostomy. Patients undergoing a Hartmann's procedure in complicated diverticulitis, those with colorectal trauma, patients who are not candidates for restorative procedures, establishing continuity with the anus or rectum, such as those with fecal incontinence, severe neurological impairment, old age, and previous resection of the anal sphincter complex. A loop colostomy can be used to divert proximal fecal flow to a problematic distal intestine or tenuous anastomosis, temporarily or permanently. The redundant, non-peritonealized nature of the sigmoid and transverse colon makes each suitable for a loop colostomy. The main indications are palliative diversion of obstructive lesions of the distal intestine, temporarily protect colorectal or colonal anastomosis, facilitate staged repair of pelvic sepsis, rectal trauma, non-healing sacral pressure ulcers, and anorectal fistulae. Like colostomies, small intestine stomas, e.g., ileostomy, jejunostomy, can be used for permanent or temporary enteric drainage and practically have similar indications. A permanent terminal ileostomy is commonly used after a total proctocolectomy and in patients not candidates for intestinal reconnection, such as in inflammatory bowel disease, hereditary colorectal cancer like familial adenomatous polyposis or Lynch syndrome. It is also indicated in patients with multiple intestinal resections, hostile abdomen, or damage control surgery in a traumatized patient. Physiology. The function of stomas depends on the level of diversion. Stomas created more proximally in the small intestine, like ileostomy, avoid the absorbing intestinal surface area and can cause nutritional, electrolytic, and fluid imbalances. The length of the small intestine is highly variable, ranging from 275 to 810 centimeters, with an average in situ length of approximately 500 centimeters, which receives 9 to 10 liters of fluid daily from proximal gastrointestinal sources. Most of the nutritional absorption from the small intestine occurs within the first 150 centimeters, as nearly 6 liters of fluid is reabsorbed in the jejunum, while only 2.5 liters is reabsorbed in the ileum. The volume of output from a terminal ileostomy can vary greatly, ranging from 200 to 1200 milliliters daily. The colon receives approximately 1500-2000 milliliters of intestinal fluid from the small intestine. It absorbs 90% of the water and excretes 100-150 milliliters of water with solid feces. Most of the water and electrolyte absorption occurs in the right colon. Therefore, the more distal the stoma, the more solid the feces. Colon peristalsis varies from 24 to 150 hours, so distal colostomies may function periodically and less frequently than proximal stomas. Finally, I'll talk about stoma complications. But before that, I invite you to subscribe to my channel and enable notifications to see more videos on medical topics. Or follow me on my social media where I share recent scientific publications and some clinical cases of mine or colleagues. Stoma problems have a profound impact on the quality of life of ostomized individuals, but can often be mitigated with proper care and education in collaboration with stoma care professionals. According to the NSQIP, the complication rate is 37% for elective cases and 55% for emergency operations. These complications can be grouped into early and late complications. Early complications occur within the first 30 days of stoma creation and include ischemia necrosis, retraction, peristomal dermatosis, bleeding, hematoma, ostomy evisceration, intestinal obstruction, fistulas, and peristomal abscesses. High output production. Late complications include stenosis, prolapse, peristomal hernia, and retraction, high output production. I'll provide a description of the complications and the factors that favor their occurrence. The treatment of each complication should be managed by a general surgeon or colorectal surgeon. Thank you very much for watching this video. I invite you to subscribe and watch the next video where I share more medical information about intestinal stomas. Thank you very much. I am Dr. Jesus Macias.